Well, thank you all. I want to thank Jeff Chen for inviting me here to speak and the UCRI. I think this is a terrific opportunity. I'll probably be raising more questions than I'm giving you answers, and I have to say this is as much an education for me as it is for you all. I also want to thank Ziva Cooper, who switched slots with me. So if you thought you were listening to Dr. Cooper now, stay tuned. She's coming at noon, and apparently I double booked two entirely different talks for the same time. So anyway, so who am I? I'm actually a pediatric oncologist by training. I specialize in a very narrow field of oncology called sarcomas. They're aggressive bone and soft tissue cancers. As our program here has become nationally renowned, while most pediatric cancers are cured, very few of my patients are cured. I think because we attract patients that are heavily treated at the fourth or fifth line of therapy, probably no more than 10 or 20% of my patients are going on for 5-year survival. Many of them, I am leading not just through diagnosis, recurrence of disease, but through the period of end of life. And so the point of that is that that's how actually I got to cannabis and cannabinoids were through my patients and families who would repeatedly ask me, can I use cannabis? Can I use cannabinoids? Will it help with my nausea? Will it help with anorexia? Will it help cure my cancer? And now, more and more, I think, in a way, frighteningly, I hear from patients and families no less than once a month, Dr. Federman, thank you for your recommendations for chemotherapy, X, Y, and Z clinical trial. We're going to try cannabis for the next few months, and we'll come back to you if we need it, if it doesn't work out. And more often than not, they come back to me, and I think that is a very concerning thing that's happening. That's really been over the last 2 years where I'm seeing that more and more. I have a couple of disclosures. I'm a speaker and a board member, advisory board member for Bayer. Has nothing to do with Roundup, don't worry. It's for a relatively new drug that was approved by the FDA for sarcomas and other cancers, and I'm an advisory board member for Zelda Therapeutics, which is a cannabis company based in Australia, really interested in clinical trials in diseases with cannabis and cannabinoids. So the objectives of this talk, I'm going on here. There we go. Here are my disclosures. Here are my objectives. So we'll be talking about where we've been with cannabinoids in clinical oncology, try to understand the current landscape of cannabinoid use in cancer patients, some available evidence in supportive and therapeutic applications, of which there's little, potential toxicities, specifically in oncology, and some future therapeutic applications moving forward. So this is where we've come from. As we all know here, there is a very long history of cannabinoids for medicinal use, probably at least over 5,000 years. And it really is not well documented, though, in clinical oncology and cancer patients until the 1900s. Does anybody know, though, who this mummy is in the right corner? No. So this is the Siberian ice mummy. She was found, she's 2,400 years old now, and she was found in Siberia in one of the frozen tundras that's thawing out because of climate change. And in fact, she was found buried with a satchel of cannabis. And when they were doing a variety of MRIs and CT scans on her, they actually found out that she had widely metastatic breast cancer and presumed that she had passed away from breast cancer, and that this cannabis satchel that she was buried with was actually for cancer-related treatment. I think it's a big jump to get there, but that is maybe the first use of, at least known use of cannabis in oncology. It's really not until the 1950s and 60s where we have the first chemotherapeutic agents based off of Sidney Farber's work at Harvard, Mass General, with the aminopterins, and then on folate derivative compounds like methotrexate, and with the nitrogen mustards, that we start to get into real cancer treatment, and then all the side effects of cancer treatment, that patients start to use illicit cannabis to control what I call CINV, which you'll hear, it's chemotherapy-induced nausea vomiting along with cancer pain. And this, in fact, is an old cannabis bottle marketed by Park Davis. In 1975, this is the first, I think, real clinical trial. This is published in the New England Journal of Medicine. And here, a synthetic delta-9 tetrahydrocannabinol, THC, is used in patients with chemotherapy and to control chemotherapy-induced nausea vomiting. And lo and behold, they found that 14 of 20 patients that had received THC versus none of the 22 placebo patients had improvement in their chemotherapy-induced nausea vomiting. So this is where the field starts, really, for us. In 1979, we have delta-9 THC that's now studied in high-dose methotrexate. In the late 70s and early 80s, we started using a lot of high-dose methotrexate, particularly in high-grade sarcomas and osteosarcoma, something that I treat. And this was done at the NCI, showing, again, an improvement, and this is both an oral and smoked version of delta-9 THC. In 1981, the NCI, National Cancer Institute, initiates a national THC distribution program. In 1981, the government sells dronabinol, or what we know as Marinol, the synthetic THC patent, to Unimed, later Roxane. In 1984, the FDA rejects Unimed's Marinol application because they felt that their clinical testing was deficient in chemotherapy-induced nausea vomiting. But in 1985, the FDA then approves Marinol after more testing and safety is performed. And they approve it associated with cancer chemotherapy after failure from conventional antiemetics. Notably, in 1988, Judge Francis Young, he was a DEA judge, actually recommends that marijuana is placed in Schedule 2, moved from Schedule 1 to Schedule 2 for nausea associated with chemotherapy, because it was felt that marijuana, in the combination of CBD and THC and other cannabidiols, actually worked potentially even better than pure THC. And in fact, that decision and that recommendation was overruled by the DEA at the time. And so what happens is that there is a groundswell, and particularly these two guys, Doblin and Kleiman, write back to the DEA after this rejected petition to move marijuana from Schedule 1 to Schedule 2, feeling that they were misinterpreting the general consensus in oncology. And he writes here that the judge seems to hang his hat on what he calls a respectable minority of physicians. What percent are you talking about? 1/2 of 1%, 1/4 of 1%? So what they did was they surveyed our clinical oncology community through our annual ASCO meeting, and sent out 1,000 plus anonymous surveys. They got back. They sent out 2,000, got back about 1,000, and of those, about 40% plus recommended a legal use of marijuana to at least one patient. And 60% agreed with the statement affirming the efficacy of marijuana in the treatment of CINV. And most considered the smoke form more effective than the legally available oral form, which was dronabinol. That was in 1991. Fast forward almost 20 years, And here we are now. A similar study is performed at our ASCO meeting, and this was actually presented as a news release. And this surveyed our oncology beliefs, practices, and knowledge regarding marijuana use across all of us, pediatrics and adult. 80% of us as clinical oncologists have discussed marijuana use and cannabis use with our patients. A little less than 50% have recommended in the past year, and I think most worrisome is that probably 30%, and that's those of us that actually think that we're knowledgeable, I would debate that, but 30%, we're a pretty overconfident group, but 30% of us thought that we were sufficiently knowledgeable. I think this is also interesting here, and that is that MM is medical marijuana, that 30% of clinical oncologists felt that medical marijuana was equally or more effective than standard pain treatment. I mean, that's really interesting. And what I think is most important is the utility as an adjunct. 2/3 of clinical oncologists felt that this was an important adjunct to our standard of care therapies for pain. In pediatric oncology, that's primarily where I operate, a very similar study is done, and this was across 650 plus pediatric oncologists in states like Illinois, Massachusetts, and Washington that had legalized cannabis. And in this case, the red and blue is interesting. The ETC are providers that are legally eligible to certify for prescribing medical marijuana. And I think what's important here is that 80 to 90% of pediatric oncologists are recommending medical marijuana or believe that it's appropriate at the end of life. I mean, that is almost all of us, 9 out of 10 of us. 9 out of 10 feel that it's appropriate for treatment of cancer with a palliative intent, and it's appropriate as well for progressive or relapse cancer. So that's really where we are in terms of what the opinions are in clinical oncologists that are seeing patients on a daily basis. We're really the boots on the ground. I think you'll hear a lot more about this from Dr. Jewett later, is whether or not cannabis and cannabinoids are effective anti-cancer therapeutics. And I think there is a lot of preclinical evidence. It's really beyond the scope of this talk, but you'll hear from Dr. Jewett specifically about all of the evidence that I think in the last decade is coming out with a variety of different cancers and different mechanisms. But there really is very little human clinical evidence other than anecdotes. And those, unfortunately, are what driving really influencing sort of patient decisions. But we know that in rats, THC and cannabinol can inhibit lung cancer, that there are CB1 and CB2 receptors in lung and breast cancer and a variety of other cancer, that there's anti-tumor effects in preclinical models, particularly in breast cancer, and that through a variety of mechanisms, CBD may enhance cytotoxic chemotherapy's action by increasing uptake into cancer cells. It may also help with the new field of immunotherapeutics in cancer in terms of helping to prime the immune system. So there are a variety of mechanisms for cannabis and cannabinoids in terms of potentiating chemotherapeutic effects in cancer. Here's one of really the two clinical trials. Oops, there we go. One of the two clinical trials that has been performed. And these were patients with a refractory recurrent glioblastoma multiforme, which is almost universally a death sentence for patients, the most aggressive brain tumor. And so these patients, after having failed surgery, radiation therapy, and standard chemotherapy received THC that was actually injected directly intratumorally into the brain. You'll note that all of these patients died. The authors did say that there was a reduction in Ki-67, that's a proliferative index, but I have to say, having reviewed the paper, I was not impressed. And I think the words of, many of you may know Don Abrams up at UCSF, who's a medical clinical oncologist and has a lot of interest in this sphere. He says, I think very wisely, what saddens and disturbs me the most is when I see a patient in consultation with a potentially curable malignancy who's foregoing conventional cancer therapy in hopes that cannabis oil will be a kinder, gentler treatment. The fact remains that there is no evidence at this time to support such a decision. And I think that is something that is really important, that we really are discussing with our patients what we know and mostly what we don't know about medicinal cannabis and cannabinoids. One of the great areas of research with more clinical evidence, and where I think, both anecdotally with my own patients and personal experience, and from a clinical research perspective, is the application of cannabis and cannabinoids in chemotherapy-induced nausea vomiting. As we've already mentioned, there are a variety of synthetic THCs that are approved for this. Dronabinol or Marinol was approved in 1986 for treatment of nausea vomiting associated with cancer in patients that have failed standard conventional antiemetic treatments. Nabilone is another version of delta-9 THC, and Syndrose, which is a liquid solution of dronabinol. And what we know is that there are cannabinoid receptors that are really in the chemoreceptor trigger zone that interact with our chemotherapeutics to promote nausea and vomiting. And these are a variety of ways that we block that with a multitude of medications. So it's not uncommon, for my patients to be on 3 to 5 different antiemetics. Zofran, a 5-HT3 antagonist, a dopamine antagonist, something like Reglan, an antihistamine like Benadryl, an NK receptor agonist like aprepitant, a benzo like Ativan. True polypharmacy. What I've seen with patients that have now decided to use cannabis because they are having difficulty with all these or having side effects from all of the other antiemetics is that, in fact, they could probably reduce their antiemetics down to 2 or 3, or those patients that felt like they were on 12-foot swells in a boat nowhere near land now actually can move around, they can get out of bed, they can eat something. So there definitely is application here, and true to form, there have been many systematic randomized controlled trials and meta-analyses that show improvement of chemotherapy-induced nausea vomiting with synthetic cannabinoids. And in fact, our National Comprehensive Cancer Center Network and American Society of Oncology guidelines do recommend synthetic cannabinoids as breakthrough treatment for CINV. What about delayed CINV? That's a major issue for those of us that are prescribing highly emetogenic chemotherapies. So there's really 2 forms of CINV, the acute form of emesis that happens as soon as we give the chemotherapy. And then there's delayed CINV that happens 3 to 5 to 7 days later when they're no longer getting chemotherapy. And this is particularly challenging to deal with. And in fact, our current antiemetics do not work very well, if at all, for delayed CINV. So there probably is a role for cannabinoids there, and that has not been well studied yet. The other question is, what about the oral synthetic cannabinoids versus inhaled marijuana versus oral cannabis edibles? And this, again, is a big question because it may, as we all know, there are hundreds of compounds within a cannabis extract, and those may also work adjunctively with pure THC. Our oncology guidelines through ASCO, however, has balked on this subject and says the evidence continues to remain insufficient to recommend medical marijuana for CINV. So that's where we are. Anorexia is a major issue with cancer patients, both in treatment because they're getting heavy doses of aggressive chemotherapeutics that not only cause emesis and nausea, but also cause anorexia and a feeling of malaise. And those of us that have been in the field know that THC and CBD potentially stimulate appetite centers. And why not use medical marijuana and medicinal cannabis and synthetic THCs to help promote appetite in patients that are suffering from anorexia, or even more severe is really cancer wasting, something we call the cancer cachexia syndrome. Interestingly, though, the studies that have been performed have really not shown an improvement of cannabis or cannabis extracts in cancer patients suffering from anorexia and anorexia cachexia syndrome. And here are two big studies, one in 243 subjects with cancer-related anorexia that found no improvement over placebo. A second study was comparing what we use regularly in patients with anorexia and cancer, megestrol acetate versus dronabinol. Found a greater increase in megestrol, so what we use works, but there was no added benefit with dronabinol. That being said, dronabinol is indicated in HIV/AIDS associated anorexia because it does increase appetite and weight stabilization. So it doesn't necessarily follow why that disease would be much different than the cachexia in cancer. But at this point, the evidence does not support it in bigger randomized trials. But I think there's more to be done here. And again, in personal experience, we've had a lot of issues with patients maintaining weight, and they seem to have improvement in appetite with cannabis and cannabinoids. Cancer pain, I think, is an area, and pain in general, and you'll hear about that later, is an area where cannabinoids potentially have their greatest use in oncology. And that's because of a variety of issues. Number one, there are numerous causes of cancer pain, which you see here. I primarily deal with malignancy-related causes from bone and soft tissue metastases, but also pain from chemotherapy. Things like neuropathy from chemotherapeutics like the platinum agents and the vinca alkaloids can be quite severe, especially in our young adults. And that is potentially really a dose-limiting toxicity to our agents that really does limit the ability for us to give full doses of potentially curative chemotherapeutics. The other thing where cannabis, I think, has potential application is because the types of cancer pain are many, both nociceptive pain and neuropathic pain, and you can see that down here with somatic, visceral, referred pain, allodynia, and on and on. And this is our current algorithm, or one of our algorithms to how we approach cancer pain. You start with an analgesic, you administer potentially palliative chemotherapy, surgery, radiation. These patients often have persistent pain, and then we step up the analgesic drug ladder to include opioids. We increase opioid doses. We include other things like muscle relaxants, nerve stabilizers like Neurontin, gabapentin, and the list goes on and on. And oftentimes we end up with patients on massive doses of opioids. So one of my recent patients who just passed away was on 180 milligrams of methadone daily. If I took that, I would be dead. But patients can tolerate that, but these patients become so somnolent that they can't do anything. So now we end up treating them with Ritalin or another stimulant to keep them awake during at least for several hours a day, so that they're not constantly sleeping. So I think polypharmacy is really at issue here. And here is, I think, a very nice study that was done. It was a multi-center, double-blind, randomized, placebo-controlled study of the efficacy, safety, and tolerability of THC CBD extract and THC extract in patients with intractable cancer-related pain. It was done by Johnson, Burnell et al., and they had an intent-to-treat population of 177 patients. And just as background for that, we know that there are CB1 receptors and CB2 receptors in the CNS and in the peripheral nervous system. And the agonists to CB1 and 2 clearly have analgesic activity. And so what they found was, I went the wrong way. What they found was, interestingly, that the THC-CBD combination produced the highest level of pain control with a 30% response rate. But interestingly, it didn't really relieve minor pain much better than a placebo, and at the highest level of 50% response, it didn't seem to be statistically much better than THC or placebo. So I think there is clearly a role, and this is not the only study that has shown an improvement in cancer-related pain. What we do need to be mindful of are the side effects here, particularly somnolence, dizziness, and confusion in our patients, and those especially that are getting higher THC type extracts. And you'll see that clearly there was a higher number that had significant treatment-related adverse events in the THC CBD group over the placebo. One of the areas that I think we're seeing a lot more cannabis use, I think this may be really in immediate future, is in the end of life. And this is Sir William Brooke O'Shaughnessy, who I just dug up a few weeks ago. It's really, I don't know if anybody knows of Sir William Brooke O'Shaughnessy. Any hands? Great. So there are a few. So I guess this guy really is one of the pioneers in cannabis research. And I didn't know until I was able to look at some of his original texts. And so he was an English/Irish physician who was knighted. He went and did a lot of his research work in a variety of natural compounds in India, and was very interested in cannabis and cannabinoids. And he was studying children and adults that were suffering from diseases where there were no cures at the time, particularly tetanus, rabies, and other infectious convulsive type diseases. And he writes here, and I think it's really prescient, it seems evident that at least one advantage was gained from the use of the remedy. The awful malady was stripped of its horrors. If not less fatal than before, it was reduced to less than the scale of suffering which precedes death for most ordinary diseases. Next to cure, the physician will perhaps esteem the means which enable him to strew the path to the tomb with flowers, and to divest of its specific terrors the most dreadful malady to which mankind is exposed. He writes this about cannabis in a child who is dying of rabies, an incurable disease. And it very much mirrors the experience that we have from patients dying of cancer. I will tell you that many, if not most, of my patients at the end of life are using CBD, cannabinoids, cannabis, THC, and a variety of different cocktails. And that it does seem to improve their appetite. It does seem to decrease some of the nausea vomiting, not from chemo, because at this point they're really not receiving chemotherapy, but they're receiving heavy doses of opioids. It may reduce the amount of opioids they actually need to take to control their cancer pain. They seem to have a sense of well-being, like Dr. O'Shaughnessy mentions here. It seems to reduce the psychological trauma, and it may enhance some of their sensory perception that we've dulled with opioids and things like benzodiazepines that we use ad nauseum at the end of life. I'm going to switch gears a tiny bit and talk about something that is asked of me all the time. Well, what about cancer incidence in cannabis use? You know, aren't you worried that your patients are going to get lung cancer or some other cancer later on? I think there's really conflicting evidence. To my knowledge, there really has not been anything that points to a higher risk of developing cancer from cannabis use, but there are some studies that show a potential link. But there are two major studies. One that was a study of almost 65,000 Kaiser patients from San Francisco and Oakland that were young adults to my age adults who, I guess I'm getting older. But I don't know what I consider myself now. But at any rate, you know, the duration of follow-up here, the mean follow-up was 8 years, which for this type of study is probably on the shorter end. But they determined that there was no risk, there was no link between marijuana use and cancer. There have been a variety of systematic reviews. This one had 19 studies evaluating cancer risk and inhaled cannabis in pre-malignant and malignant lung lesions that failed to demonstrate an association. So I think, you know, as time goes on, we'll have a better idea. I generally will not recommend that my patients smoke or inhale cannabis, but to each their own. Another interesting issue in oncology and in any field in medicine is the formulations and pharmacokinetics here. And what we do know is that different formulations and the way that you administer it have different pharmacokinetics and bioavailability. I think that is always important to take into account. We know that the peak plasma concentration of oral THC occurs in 1 to 6 hours, depending, and has a much longer terminal half-life, whereas inhaled cannabinoids are rapidly absorbed with a peak concentration of 2 to 10 minutes, but decline rapidly over 30 minutes. And, you know, I've seen a variety of studies. The numbers are not exact here. We also know that cannabinoids interact with cytochrome P450, and that is a potential issue, not just with chemotherapeutics, but with a whole host of medications, and the list gets longer and longer every day that I put a patient on clinical trial, and it tells me to avoid P450 inducers or inhibitors. There's like, you know, 200 to 300 medications on that list. And so we know that cannabis is metabolized by cytochrome P450. We also know that THC is a CYP1A2 inducer. So theoretically, it can decrease certain concentrations of some important drugs that we use all the time. We also know that CBD is a potent inhibitor of CYP3A4 and CYP2D6, so that CYP3A4 substrate medications, their concentrations might increase. You know, my patients using cannabinoids with chemotherapeutics, I've not seen any interactions either with increased drug levels, because we frequently do check chemotherapeutic levels like methotrexate, or with decreased activity, or with hypertoxicity. And there have been very few studies looking at the combination of cannabis and cannabinoids with plasma PKs of commonly used therapeutics. Irinotecan and docetaxel are both substrates of CYP3A4, and two studies did not show an effect on the plasma PK. But we need a lot more clinical trials to really assess potential interactions before we truly can say that co-administration of cannabinoids, while we believe it's safe, it really needs to be proved. So where do we go from here? We say in our comprehensive cancer center here that the end of cancer begins with research. That is always the case. We need more clinical trials. We need more evidence. And this is a smattering of available clinical trials now studying cannabis and cannabinoids in cancer. What I want you to realize here is that there's only one phase 1 study that is currently recruiting. And these are cannabis cigarettes that are provided by the NIDA with a high CBD and low THC content. The rest of these studies are all observational pilot or observational prospective studies. So I don't think we're going to learn a lot from these studies in terms of utilizing cannabis, cannabinoids, and medical marijuana into the concurrent care of oncology patients. So this is really an entreaty to all of you that we have to push better clinical trials. We need phase 1, phase 2, and large collaborative phase 3 clinical trials in both medical, adult oncology, and pediatric oncology. So with that, I'm going to conclude and open this up for questions. We know that cannabis has had a long history in oncology over the last century, at least. I believe the greatest application is going to be in supportive care and symptom management in oncology, CINV, anorexia, and cancer pain. I think there will be a role for cannabinoids and cannabis in combination with current chemotherapeutic regimens for cancer treatment, but we need more clinical evidence, and there is really no evidence at this point to support CBD and THC as cancer treatments to help cure them of disease, and clearly large prospective clinical trials need to be performed so we can advance the field. So with that, I'm going to open that up to questions. Thank you.
There are some studies, mostly retrospective, suggesting that we should avoid using cannabis in patients that are getting immune therapy. And I'm very confused as to whether that's important or not. My gut feeling is that it probably isn't, but I just don't know what to do with those patients at this point.
So that is, and you'll probably hear some of the preclinical evidence for where that comes from. We believe that potentially cannabis and cannabinoids can interfere with the immune system, which might work directly against immunotherapy, what we're trying to do with immunotherapy, but there's conflicting data. There's also data that it might actually improve the checkpoint inhibitors, some things that we're using now in melanoma, head and neck cancer, squamous cell, et cetera, that it might actually improve the response. I don't think we can say one way or the other to avoid cannabinoids and immune therapy. We certainly use a lot of steroids in patients on immunotherapy to mitigate the side effects of the immunotherapeutics. And and it doesn't seem to decrease the effect of our immunotherapeutics from an oncology standpoint.
And one other thing, when we're treating our cancer patients, for a number of years we were using more THC than had CBD, which helps for their anxiety. But in the last 2 or 3 years, we've been adding, which has made a tremendous difference, CBDA and THCA to THC and CBD, and use all 4 in combination. And that works unbelievably well.
Right. So I think there's an avenue for exploration. We clearly have an FDA-approved synthetic THC, which leaves out all the different compounds that may be in a whole cannabis extract that may be providing beneficial effects and may also add to toxicity. And we have to recognize the potential for toxicity to these other agents. It's not uncommon that my patients will show me some cannabis extract that they're using, and from patient to patient, it's amazing how they can get all of these different formulations. And so it's really impossible for me to say one way or the other which one is good or bad. We are very aware of the toxicity from THC, and certainly with somnolence, dizziness, we've had patients actually become totally psychotic, and probably not directly from the THC, but from a combination of THC, opioids, benzodiazepines, and and antihistamines, where that's just enough to push them over the edge. So.
Hi, thank you so much for the talk. That was very interesting and informative. My question relates more to care and symptom management regarding pain and cancer treatment. You discussed the analgesic drug ladder and just how many cancer patients are being prescribed these massive doses of opioids, and they become so lethargic, basically, that we have to treat them with ADHD medication. I was wondering if if really you or the community within clinical oncology are looking towards research, particularly Dr. Cooper's research regarding the synergetic effects of sort of co-administration of cannabis and a sort of lower than effective opioid dose, and how that can actually prove to be an effective dose of an opioid, and if really people in the community are listening to this research.
So I think that's an important, and I didn't speak of that specifically. Maybe Dr. Cooper will speak about it. She will. Thank you. So she's going to address some of that, but it is, I think, a really great application for us as oncologists and as palliative care physicians to try and reduce the polypharmacy in our patients and reduce opioid use in our patients, both at the end of life and during cancer treatment and afterwards. It's not uncommon that, I've had 2 patients that I've had to put into a substance abuse program after we've cured them of cancer. That's horrifying. And one of the ways, anecdotally, that we were able to get a patient off of opioids is with concurrent use of cannabinoids. So the application is there. We need to study it. And any other questions?
Yes. On the active NIH study you mentioned, which is looking at the tolerability of cannabis with the concurrent use of chemoradiation with glioblastoma. Mm-hmm. Can you talk about what the hypothesis is? So you talk about tolerability, but what exactly are you looking for? Are you looking to see if it's going to actually improve the chemotherapy effectiveness? Are you looking to see, basically what are you looking for?
So I'm not looking, that's not my trial, so I'm not looking specifically, but the investigators that are doing that trial it's a phase 1 trial. So they're really specifically, they're not looking at efficacy. They're looking at safety, pharmacokinetics, and tolerability associated with radiation and chemotherapy. And that's sort of a classic phase 1 approach. It may seem backwards to many of you. Well, why don't we just go, we know it's safe and tolerable, and that's actually not the case. We do need to do these studies. We need to do it in formulations that are reproducible over and over again. That's a major problem that we have here. So we need to do it in formulations that we know from one batch to the next, it's the same thing. And so that's what this study is doing.
Is there a phase 2 planned for it? Because if they're testing for tolerability, I assume it's for a specific, hypothesis again. So I'm just trying to understand what
so there's a
for.
phase 2 plan, right? Assuming that it's safe and tolerable, which we're assuming it is.
Thank you.
I was very intrigued by the oral persistence of the effect for 20 hours. And so I would suggest there's some study needed of the microbiome in regard to cannabinoid administration. And I think there's an overemphasis on the drug-nutrient interactions generally in the literature, because these are in vitro assessments of interactions. And I always tick off the pharmacologists when I tell them these are phytonutrient metabolizing enzymes, not drug metabolizing enzymes, because there were no drugs 50,000 years ago. So this is expected that there's an interaction, and there's a big overemphasis for grapefruit juice and statins and lots of examples of this. So I just a note of caution about worrying about that too much.
So I couldn't agree more with you. on both points. So the first point is I'm not a microbiome person, but I think this is a field that is ripe for discovery, which is interactions of cannabis, oral cannabis and cannabinoids on the microbiome. So whoever wants to take that on, and I'm happy to have my patients submit stool and saliva samples to you. The second point is well taken, and that is that what we know about metabolism, drug metabolism, mostly is preclinical data. And again, many of us that use or have supervised the care of patients that are on cannabis and cannabinoid formulations have not been that impressed with drug interactions. And so I agree with you. I think that's why we really need to prove in systematic clinical trials that we can use these concurrently without major toxicity, without increasing or decreasing the efficacy of standard regimens.
And when you say not impressed, you're meaning you haven't seen a strong suspicion that there's a...
That's what I mean,
interaction.
yes, yeah.
Okay.
Being not impressed is a good thing in my field.
Right. Time for one last very quick question.
Thank you for the talk. Can you explain the reason why there's such a shockingly low number of trials happening?
Oh, man. Yeah, I don't think I have enough time for this. I think you've heard in the first talk some of the legal hurdles here. I think the major hurdle is the Schedule I classification. Am I right, Ziva? I mean, that's the major issue. What's that? Funding goes along with that, and I think we hope that and part of the reason Jeff is here is to help facilitate that this research happens and gets through places like the University of California in a way that we can conduct research, and it is frustrating that there isn't more going on. I think we're poised, particularly here at UCLA, University of Colorado. There are a couple of places across the country that the moment we can reclassify cannabis and cannabinoids, we can move ahead very quickly and hopefully in a collaborative manner. Okay.
Thank you, Dr. Federman.
Thanks.
Thank you so much. Round of applause for Dr. Noah Federman.